Welcome, everyone. I am so excited to have you with us today. Please let me know that you can see and hear me by saying hello in the chat. Today's workshop, When Children Get Liver Cancer, is produced by Blue Fairy, the Adrienne Wilson Liver Cancer Association, and sponsored by Eureka Therapeutics. Blue Fairy is a nonprofit organization. Our mission is to prevent, treat, and cure primary liver cancer, specifically hepatocellular carcinoma, also known as HCC. Please remember that, HCC, through research, education, and advocacy. Eureka Therapeutics is a clinical stage biopharmaceutical company located in the Bay Area in Northern California. Eureka is focused on harnessing the evolutionary power of T cells, which we will talk about today, to fight solid tumors. Eureka currently has 3 ongoing clinical trials in liver cancer, and you're going to hear more about that later today. I'm going to tell you a little bit about the workshop today and how you can interact with our incredible panelists. First of all, please continue to chat with each other and get to know each other. If you have a question, however, don't put it in the chat. There's a fantastic function. If you look toward the bottom that says ask a question, that's where we want you to post all of your questions. We're going to have a live Q&A with all of our panelists at the top of the hour. So please put all of your questions there. Also, you can see other people's questions. That's the beauty of that function. And you can vote questions up if you want to hear the answer. So you can upvote people's questions. I'm going to tell you a little bit about our panelists today. So we have the expert's perspective with Dr. Allison O'Neill. We have the patient perspective with Ashley Bengali. We have the survivor's perspective with our pediatric cancer survivor, Presley Alarcon. We have the scientist and rare disease patient advocate perspective with Dr. Pei Wang. So we have 4 incredible women today that are sharing 4 very different perspectives about liver cancer. And we are also going to bring on Dr. Wang and Dr. O'Neill together to talk about what clinical trials Eureka currently has for patients who have liver cancer. We are inviting Dr. Allison O'Neill to the stage, and let me tell you a little bit about her. Dr. O'Neill is a pediatric oncologist at Dana-Farber Cancer Institute, where she serves as the director of the Solid Tumor Program and the Liver Tumor Center of Excellence. Her research interest lies in the development of novel therapeutics for pediatric patients with solid tumors, particularly those with liver tumors. Dr. O'Neill, thank you so much for joining the live workshop today.
Thank you for having me. It's an absolute pleasure to be here. It's so excited to see so many people from all over the world and a lot of familiar names too of patients and families I've been honored to meet and care for along the way. So it's so nice to know you're there.
Before we talk about what liver tumors are, what liver cancer is, how did you become a leader in this field? Did you always want to work in liver cancer?
It's a great question. And so much, as we all know about life, is that you have a circuitous course sometimes. When I was in undergraduate, I actually was offered a position in a laboratory studying livers. And it wasn't liver cancer at the time, but it was understanding the ins and outs of calcium signaling and bile secretion in the liver. And I never thought that that would be, setting the stage for next steps in my life. When I finished my training up in Boston, at the time, the person caring for patients with liver tumors asked if it was something I was interested in taking over. And that was over a decade ago, and I didn't have a strong opinion, but of course said yes. And my life has changed immeasurably as a result of that decision. I've been so very fortunate to have the opportunity to be engaged with so many other providers in the United States, internationally, abroad, and we have such a unified community of caregivers that are so very passionate about diseases affecting children, particularly liver cancer. I know that the first patient I ever treated with hepatocellular carcinoma remains a child that I continue to keep in touch with, a family I continue to keep in touch with. And that particular patient, I think, taught me a tremendous amount about a rare, particularly rare entity affecting children, and really ignited within me a passion to do better for children like him and children diagnosed with similar cancers in the future.
Oh, wow. Well, I'm just excited to hear that that patient is still alive today. That's fantastic. And I agree, this is a very, very special community. And I see someone's already asked a question. Excellent. A reminder, put all your questions in the ask a question, and we will be answering all those at the top of the hour. So, Dr. O'Neill, can you tell us, first of all, what is a liver tumor and also the most common types?
When we think about liver tumors in children, they are just that. They are tumors that arise within the liver. So the primary tumor grows from the liver tissue itself. It hasn't arisen elsewhere and spread to the liver, and in fact originates from the liver. When we think about liver cancers in children, there are a multitude that can occur, but the two most common are hepatoblastoma and hepatocellular carcinoma. Hepatoblastoma we won't spend much time on today, of course, because our focus is really the latter. But hepatoblastoma traditionally tends to affect children with a median age of around 3 years, but up to around 5 years of age and occasionally older. Hepatocellular carcinoma, which we'll refer to as HCC, as you led in with, just for ease, traditionally affects an older patient population. We know that children affected with HCC can be at a median age of around 10 or 12 years of age. That doesn't exclude the possibility that the disease can occur in very young children, and then certainly older children, adolescents, and into young adulthood. And when we think about HCC, we traditionally think about two subtypes, one being conventional HCC or standard HCC, and the other being fibrolamellar carcinoma. The reality is fibrolamellar is a completely different disease. It has very different genetics. In fact, we're slowly starting to understand more about that disease, and we recognize it's really in its own category, very different from conventional HCC. So we'll put that disease aside for the moment, knowing that the challenges we face, the treatments we choose are very different between the two entities. Conventional HCC, you think about HCC and you often associate it with adults, and adults with liver abnormalities, cirrhosis, a sick liver that then generates a tumor like this. Interestingly, in children, HCC only occurs about 20% of the time in a sick liver or a cirrhotic liver. The vast majority of cases are what's called de novo. They arise in a completely, at least to our knowledge, healthy liver, looks healthy under the microscope, functions normally, and yet these tumors grow. And so they're definitively different from the type of HCC tumors we believe that occur in adults. We know they behave differently, they respond to different therapies differently, but they present a significant challenge because more often than not, children come to medical attention and the disease has already spread or is already advanced. And that makes them very difficult to treat adequately and to cure.
And without scaring anyone, what are the common symptoms of having liver cancer regardless of your age?
And I'm glad you led in with not to scare anyone. The realities are, you're right. I think the way I often counsel families, it's traditionally symptoms that don't go away. And those may include significant abdominal pain, a palpable mass, in the right upper quadrant of the abdomen, a child who's losing weight for unexplainable reasons, or a child that feels full early. And often if you have a large mass, it gets in the way of the stomach and the way the stomach empties. And so while people want to eat, they don't necessarily feel as though they can, or they get full early. In very young children who can't, of course, tell us all of these things, it's a little harder, of course, and children just aren't themselves. As I mentioned, they may be losing weight, they may have unexplained fevers. And then, of course, any kind of palpable mass should always flag a parent to have their patient seen or their child seen by a provider. I think it's those nagging symptoms. A lot of parents have wonderful intuition. They know their children best. When there are unexplainable symptoms that aren't going away, much along the lines of what I described, that's when you can push your doctors to really think further into whether liver tumors are a possibility.
Thank you. That is so helpful. With my sister, as you know, she had the more common standard HCC, and the day she felt that first symptom, she couldn't breathe, and her liver had gotten so enlarged it was just pressing on her diaphragm. We didn't know what it meant that she couldn't breathe, but prior to that, she really had no symptoms other than acid reflux, which is very common. So thank you for that. You mentioned that fibrolamellar is a very different disease. So in terms of treatment, how is HCC different from fibrolamellar and different from hepatoblastoma?
They're all very different in truth. I think the challenge we face, hepatoblastoma, thankfully, is very chemotherapy responsive. All of these tumors, however, are dependent upon two very important modalities. One is what we call systemic treatment of the whole body through medicines that can help, confine the tumor to its location, treat whatever circulating disease exists, and then the second is surgery. Surgery is so very important. In the hepatoblastoma world, we're more fortunate. Those tumors respond typically quite well to standard chemotherapy, and we can often get children to a surgery. Now, that's not always the case, and there are some challenging hepatoblastoma cases to treat. But the majority, thankfully, are more chemotherapy responsive. When we think about HCC, be it conventional or fibrolamellar, these tumors don't respond to chemotherapy as well as we would hope. They tend to respond to chemotherapy better than the adult subtypes at times, although that probably holds true more so for conventional HCC than fibrolamellar. When we think about the treatments that we can capitalize on to treat these tumors, then we do often start with chemotherapy in many instances because we tend to want to burden reduce tumors if we can. Because surgery is so important, a lot of times a surgery can be very difficult at the outset, not impossible, and when you can take it out in the beginning, you try. But if there's a mechanism by which to shrink the tumors or to reduce the burden of disease in the body to get a patient more safely to surgery or more successfully to surgery, we traditionally try, if we can, with medications that treat, as I mentioned, the whole body or attempt to shrink the tumor. So when we think about available therapies, we think about three big buckets, or that's kind of how I like to explain it and think about it. One is chemotherapy, as I mentioned, which is of limited utility to us, but certainly a place we tend to start. The current enrolling Children's Oncology Group trial, which is a national trial through COG, or the Children's Oncology Group, actually utilizes chemotherapy in the upfront setting. And we've seen some brilliant responses for pediatric patients, which again sets the disease apart a bit in my mind from the adult conventional HCC. There's a second bucket of more targeted agents. Those include drugs that target blood vessel formation or specific enzymes within the tumor. They're not always used alone, often in combination with chemotherapies or with other agents, and they tend to work better when used synergistically with other types of drugs. And the third bucket is immunotherapies, and this is where I think there's a lot of excitement to come, and I know that we'll discuss immunotherapies in particular in a bit. What I'm learning personally in my practice is that the immune system is only so good provided you can reduce the burden of disease in the body first. If we call on the immune system to try and attack the tumor, it usually works best in what we call a minimal disease setting. And so the challenge we face as providers is trying to get patients to that state such that we can then turn to these novel agents with the hope of impacting long-term survival.
How often is immunotherapy used right now with HCC or hepatoblastoma?
I would say that it's certainly more commonly entertained for HCC. In hepatoblastoma, we're learning more and more, and in patients that have multiply relapsed or refractory disease, i.e. disease that isn't responding as we'd expect up front, we find that immunotherapy might be the right approach in patients like that because those tumors tend to change dramatically over time and become more and more abnormal and perhaps more apt to respond to immunotherapy. The challenge with immunotherapy is we often rely on, as I mentioned, immunotherapy by virtue of the class of drugs, so to speak, is to try and get the patient's own immune system to reawaken, to notice the tumor in a meaningful way. Because in truth, the tumor probably grew because it went unnoticed by the immune system. So how then do you turn the immune system on to recognize the tumor as foreign and to meaningfully attack? We've found from the adult world that tumors that respond best to immunotherapy are those that are really genetically dysregulated. By that, I mean the genetics are kind of a mess within the tumor. And so the tumor really looks foreign to the body, and you can trigger the immune system to recognize that foreignness better. In children, for some reason, the tumors are less dysregulated, so they look less foreign. So we've had to become pretty creative in terms of thinking about how to trigger the immune system in a meaningful way. And we've slowly evolved to do that, and I think HCC is the perfect disease to think about for immunotherapeutics in children because the disease, while different from adult HCC, best approximates that degree of dysregulation. So if any tumor is to respond, my bet is that hepatocellular carcinoma is the one that we might have the most success with. We've started utilizing drugs like checkpoint inhibitors. Those are antibodies intended to reawaken the particular immune cells of interest. And of course, we'll talk more when we meet Dr. Wang and others from Eureka. We'll talk about the clinical trial that we've worked on together that is intended to utilize the immune system to recognize these tumors.
We're going to say goodbye to Dr. O'Neill just temporarily, and we're going to invite someone very, very special to the stage. So if you could just bear with me Ashley Bingley is an ER nurse, and she's the mother of Presley Alarcon. Presley is a liver transplant recipient and a primary liver cancer survivor. Her life took a complete turn when she was unexpectedly diagnosed with hepatocellular carcinoma, again HCC, in July of 2020. Presley loved her life before cancer, and she loves it even more now, and she enjoys sharing her story and educating others about the occurrence of HCC in pediatric patients. Thank you so much, Ashley and Presley, for joining us. We are going to jump in first, Ashley, with you. Tell us, prior to Presley being diagnosed, what was your perception about children getting liver cancer?
I had briefly heard of hepatoblastoma. I knew younger kids could get hepatoblastoma, but I honestly had no idea that someone Presley's age could get liver cancer, primary liver cancer.
What happened in April 2020 that led you to believe that something was wrong with Presley's health?
So Presley had some blood in her urine. She wasn't feeling sick. She didn't have any symptoms, but I took her to her pediatrician thinking she might have some type of infection or maybe she was dehydrated, and everything came up normal. Yeah, that was in April. So she just had one episode of kind of like blood in the urine with no symptoms, no fever, no back pain, no belly pain, just an isolated episode of blood in the urine.
And I'm going to come back to that. So Presley, in your words, before your diagnosis, before there was ever blood in your urine, what was your life like? I understand that you were quite active.
So I used to play a lot of sports. Primarily I would play lacrosse and softball, and I would just like to be a typical teenager, like go out with friends and do anything a normal teenager would.
And let me ask you before we go back to your mom, were you concerned when there was blood in your urine?
Not necessarily, because I've always known that I was such a healthy child. It didn't really concern me, but it kind of made me question why, because I would have no reason behind why.
Ashley, back to you. So you thought it was a lack of hydration, but the blood work comes back and everything's good. It's perfect. Why did you continue to believe that something was wrong with Presley?
I just thought, I really focused in on something being wrong with her kidneys, honestly. It was just the start of COVID and, kids weren't in school. So I thought, hey, Presley, you're being lazy. You're not drinking enough water. Maybe something happened to your kidneys. So that's kind of what led me to talk to her pediatrician and just kind of investigate a little bit more. But for me personally, I was more zoning in on her kidneys, not her liver, not at all.
You were concerned, you were still concerned, and then there was an ultrasound done. What did that ultrasound show, you guys?
So the ultrasound showed that she had a mass in her liver when they were evaluating her kidneys. It was a huge, huge surprise.
Then after that, you needed to get an MRI. Tell us about sort of the trouble you had with getting that MRI. The ultrasound was in June, and tell us about the MRI.
It was a bit difficult to schedule an MRI because of, I guess, kind of COVID and everything. We had an ultrasound in June, and they were kind of anticipating that we would be able to get an MRI in August. And I thought, oh, wow, that's really long.
Right, 2 months.
Right. So I just needed to investigate and figure out, kind of what was going on and why she had this tumor in her liver.
And ultimately, tell everyone, because I think it's just so inspiring, how did you finally get that MRI before August? How did you get it done?
So I actually had to take her into the ER and talk to them about it. And, at this time now, Presley, was kind of having belly pain and stuff. Just looking back, I think it was maybe nerves at the time, just not knowing because she had an ultrasound. And so I took her to an ER, and they kind of investigated and did blood work and then did an MRI. And we got that information from an ER.
And what did the radiologist say about the MRI?
It was super confusing. Me being in the medical field, I didn't even understand it. There was a lot of eliminating. It's probably not an infection. It's probably not a fungus. It's probably not, X, Y, and Z. But they thought maybe it was hepatoblastoma, and to kind of do some more lab work like the AFP level and stuff to correlate.
Despite her age, Presley, you were 14 at the time. Is that correct? And as Dr. O'Neill already told us, that's very unusual to have hepatoblastoma. And anyone over the age of 5. So it's interesting they thought it would be that. Presley, was there a time during that summer that you became worried about your health?
I wouldn't say necessarily worried. I would say puzzled
Okay.
because I didn't really understand what was going on at the time, and then I didn't have like a very clear like understanding of what was going on with me specifically.
Okay. And you get that confusing result from the radiologist. You get a referral to an oncologist. And this is while you were still in San Diego, which is where you're from. Tell us about that first appointment with the oncologist.
That was confusing as well. First of all, I didn't even know why we were meeting with an oncologist. I was focused on her liver and trying to meet with a gastroenterologist. So we met with an oncologist. Right off the bat, she told us that she thought it was benign. Presley was so healthy and her blood work looked so good that she would venture to say that it was something benign. So she went to speak to, I believe, the radiologist who was reviewing Presley's MRI. This is at a pediatric hospital.
Okay.
And then she came back and her whole demeanor changed and her whole body language and everything. And I just picked up on that right away. I was like, oh, wow, something changed.
Did you mention the AFP yet?
We didn't have that yet until we had done the lab work that day.
And for, we'll make sure Dr. O'Neill touches on this as well, but AFP stands for alpha fetoprotein, and alpha fetoprotein can be elevated with people who have liver cancer. Also can be elevated in women who are pregnant as well. So it's not specific to liver cancer necessarily. So tell us about the AFP level and what the oncologist wanted to do next.
So Presley had blood work done that day, and then later on in the afternoon towards the evening, the doctor had called and said Presley's AFP level was 4,000. And I said, oh, okay, I didn't really know about an AFP. And I asked her what was the normal, and she told me less than 6. And I was like, well, what do we do?
Right.
And so she had opted to, she said, I'm going to go ahead and enroll her in a clinical trial for 9 weeks.
So I think that's interesting, right? Because there was no biopsy yet, correct?
No.
And she wanted to enroll her in a clinical trial for 9 weeks. What was your reaction to that as a parent and also as a healthcare provider yourself?
I don't know. It's kind of foggy, when you think about it. And for me, I'm like, a clinical trial for what? What are
Exactly.
we was my main thing. We only had blood work and an MRI and an ultrasound. We didn't have a biopsy. We didn't have a definitive diagnosis of anything. So I was just like, whoa, huge red flag. What are we putting her in a clinical trial for?
What did you think, Presley, when you heard about this clinical trial?
I didn't really understand what like a clinical trial was like until like I heard that it had stuff to do with cancer. I didn't really understand what it was and what it was for.
Ashley, you opted not to do the clinical trial, at least not that one.
Mm-hmm.
And you spent a lot of time looking for experts. Can you tell us a little bit about that? Because I think almost every patient and caregiver I've ever met can relate to this search that you had.
I wasn't thinking even at that time that Presley had cancer. I didn't know about this. And so I was really focusing in on a gastroenterologist. I was really focusing on like, hey, let me get her somewhere. I don't know if she was born with this. I don't know what's going on. So I did some research and I was trying to meet with a gastroenterologist in San Francisco for her. Here where we were wasn't going to be the right place for her based on, some of those red flags. So I was really zoning in and honing in on a gastroenterologist, not an oncologist at all.
And how did you ultimately end up at Children's Hospital of, I believe it's Philadelphia, right? It's not Pennsylvania, it's CHOP for short is the acronym. How did you ultimately end up moving across the country and going to CHOP? How did that happen?
I was looking for research and stuff, and bottom line, it just comes down to they picked up the phone and they said, go ahead and submit whatever you have. And things got started from there.
After you got a definitive diagnosis, you had a biopsy. So Presley, did you have any concerns about the biopsy? What were your questions?
Everything was kind of new to me, and I just didn't really have an understanding of anything and like what it would do to help figure out my diagnosis. But when I had it done, I didn't have a clear understanding of why I needed all these different types of procedures. to
Were you
figure out my
scared about being put to sleep for a biopsy?
I wasn't necessarily scared of being put to sleep. I was kind of nervous on not being put to sleep. The oncologist that we had here locally, she did not want to put me to sleep. She just wanted like to numb my local area, and I was like,
That sounds painful.
yeah, I don't really want to know what's going on.
You're right. So you get the biopsy. I know you also had another scan. Ashley, what was the next scan and what did that biopsy show?
So we got a biopsy back that showed that she had hepatocellular carcinoma. It was considered well differentiated at that time. And then they proceeded next with a PET scan. My understanding was they were looking for any signs of the disease outside of the liver.
And what did the PET scan show?
Most of the tumor and the baby tumors were on the right side, on the right lobe of the liver. But after the PET scan, I believe something showed up on the left side of the liver that they were concerned for that was starting to spread to the left side.
Is that what made her eligible and more ideal for a transplant versus just
Correct.
surgery?
Correct.
Okay. How long was Presley on the transplant list?
Presley was on the transplant list for 10 days before she received her liver transplant.
And can you tell everyone, you did get that first call after 5 days and what
We
happened
did.
with that?
It was super early in the morning, maybe like 2:00 in the morning. And, the phone rings and we pick it up and they say, hey, come down here. We have a liver for you. So, whoa, you're like, whoa, okay. So we head down there. She gets prepped, to go to the operating room and have the transplant done. And ultimately they opted not to use that liver. I don't know if it was a size thing but they declined the liver after, I guess, thoroughly evaluating it.
I'm glad you mentioned that because the size of the liver does matter if you're putting a cadaver liver from a deceased donor into a person. So Presley, how did you feel when you heard that you had liver cancer?
I'm pretty shocked because I didn't think liver cancer was an actual thing. When you think of cancer, you usually think of like the most common ones like breast cancer or leukemia, but liver cancer in a teenager like me, I would have never guessed that.
And you didn't have any jaundice, correct? Any yellowing of your skin, which can happen with liver disease and liver cancer. Did you feel sick?
No.
Is there anything that changed your mind? I know when we talked about this before, you said you were in quite a bit of denial. Was there any moment that, you suddenly realized, oh yeah, this is real, I have liver cancer?
I wanted to deny the fact that, because I just felt as if my oncologist just wanted to put a title on the diagnosis, and because I'm not sure if she was completely sure I had cancer, and I didn't want to know that I had cancer. But as soon as I got that second call, and as soon as I saw my liver dragging across the bottom of the curtain in a cooler with hazard signs on it, I knew maybe I do have cancer.
So I do want to talk about this. Ashley, you told me when we were talking earlier that it was almost like the movies. Tell us what you meant by that.
Yeah, it's kind of like when you see in the movies or something and someone gives you a phone call and you jump up and you rush down to the hospital and you get all prepared and you're ready to go. It's almost exactly like that, and you just don't have time. You're just, focused on getting down there and having the transplant and doing, what's best.
And Presley, how did you feel when you realized, oh, this is real, there's a liver in a cooler, that's my new liver? How did you feel?
I was scared. I was really scared because I go from my pediatrician not even recognizing me because I haven't been to the doctors in so long, to being like the top priority in a hospital, trying to get my life saved and trying to prevent this cancer from spreading anywhere else.
Wow. So I do have one more question for you, Presley. In August, it will be 2 years since your transplant. How are you doing today? I follow you on Instagram. I don't want to give it away, but how are you doing today?
I'm doing pretty well. I went back to doing what I was previously doing before I found out I had cancer, and I just feel a lot happier and a lot more experienced with cancer, and I've learned a lot from it.
And I know that you recently went to prom. Is that correct?
I did.
All right. As we wrap up this part of our panel, Ashley, I want to come back to you as again, as a parent, as a mother, as a nurse. I know that there were a couple of red flags. Can you walk us through what some of those red flags were?
Yeah, so that initial meeting with our oncologist locally, kind of some of the things that she said, I was like, that's kind of odd. Right off the bat, saying she thought it was benign, and then saying, she kind of wanted to put her in a clinical trial. And we didn't know about what we were treating. And then there was a couple of comments that weren't prompted or anything, and along the lines of, it doesn't matter if you go somewhere else or wherever you take her, everybody's going to do the same thing for her. And I was like, okay, well, kind of a couple of little red flags. And again, like I said, these weren't prompted by anything. They were just coming from this oncologist. And I had asked, have you ever seen anything like this? And the oncologist said, well, we treat everything. And I said, okay, I understand, but have you ever seen this before?
Have you ever seen this specifically?
Right. And again, the response was, we treat everything. No, I don't think so. It's a little odd for me.
Pay attention to the red flags, right? Pay attention. So I just want to make sure if you have questions for Presley or Ashley, put them in that Q&A. We are going to say goodbye to them for now. And we are going to welcome Dr. Pei Wang up to the stage. So ladies, stick around as we wait for Dr. Wang. Let me tell you about her. Dr. Wang serves as the Vice President of Clinical Development and Technical Operations at Eureka Therapeutics, leading the overall strategic direction and optional excellence of the Clinical Development Department. Dr. Wang holds a PhD in molecular genetics and microbiology from UT Austin. And she's also a mom of 2 sons with rare disease. And that's what gives Dr. Wang such a unique perspective as both a scientist and a parent. Dr. Wang, thank you so much for joining us. Can you tell us what type of rare disease do your sons have?
Thank you for having me here. And thank you for co-sponsoring this event with Eureka Therapeutics. It is really amazing to see people actually from all over the world. When I shared my story with Andrea, and she kind of pressed me to also share my personal stories. And so here we are. My sons have a ultra rare and progressive genetic disease. As many of you know, ultra rare disease is seldom known by people and even by the specialists.
What's the name of that disease and what type of disease is it?
It's called Hunter syndrome. It's a lysosome storage disorder disease.
How were your sons originally diagnosed?
So as I just mentioned, it's a progressive disease in their early stage of life. You won't be able to tell much of the difference of them from the typically developing kids. As the time goes by, when my oldest one was about 3.5, we definitely saw some difference, and we brought up those difference to our pediatrician. But it's really unfortunate. It's an ultra rare disease, and she wouldn't even to help us in terms of even a speculation what type of disease my sons have. It is definitely a diagnostic odyssey, I would say. We were actually considered lucky because it only took us 6 months to get the final diagnosis. We have gone through all kinds of specialists, neurologists, surgeons, and finally to the geneticist.
Was there something in particular that you noticed? You said there were some signs. What were those signs specifically?
It's really their hands are kind of not claw-shaped, and also there's some language delays, some kind of developmental milestone delay, and so made us paying attention to what this really is for our kids.
6 months. That is a diagnostic odyssey. I love that phrase. How did you and your husband feel when you finally got that diagnosis?
Shocking. And I still remember the day the appointment was scheduled after our work hour. It was at 7. And we thought that must be something serious, because normally you won't have an appointment after work hours. And we walked into the geneticist's office, and he told us his speculation of the disease type that my older son might have, but he still needs to do some testings to confirm the disease. And he looked at my younger one because we brought both of our sons to his office. And he said, you probably also need to get your younger son diagnosed too.
How old were they at the time when this occurred?
My older one was 3.5, and my younger one was just getting 1 year old.
I know both you and your husband are scientists. What accommodations have you had to make as a family to get your sons the treatment they need?
Right after we know the diagnosis of our sons, and we know it's an ultra rare disease, and we know there were not many treatment options for them. And so the first thing we did was to investigate whether there's any clinical trials that are incorporating some new technologies and that might be helpful for my kids. We also kind of trying to learn, although we're scientists, we're really not involved in a clinical trial, so we don't really know what it means to us. And so later on, we know participating in a clinical trial is definitely a life-changing event. It definitely will impact your overall life, your work schedule, your finances, and more. So you have to be prepared to sacrifice wherever it needs for your loved ones. It's definitely a roller coaster.
Let's dive a little deeper in that. How long have your sons been in clinical trials?
As of today, roughly 10 years already.
How much of your time would you say that you spend in the hospital?
They're getting a weekly treatment. As I just mentioned, even to today, there's no cure for this disease. And so we have to really constantly looking for a clinical trial that we can participate. So in addition to those daily, weekly treatment and routine checkups of everything, every organ, we also are actively participating in a clinical trial, which, as you can imagine, it will also take some time. So overall, in the past 10 years, ever since our sons were diagnosed, we spent roughly 15% of our lifetime in the hospitals. If there's one thing I learned, you have to, at a certain point, to accept that hospital is part of your home, and the clinical team is part of your family.
How has being a scientist influenced those medical decisions that you have made for your sons over the past decade?
I think as a scientist, we probably have more knowledge than others in terms of telling the pros and cons of let's say, a new technology that the clinical trial is using. And we may have a better idea of weighing the safety, the quality of life, and the versus long-term benefit to help us make hopefully a better decision of what type of trials my kids should participate, in what phase of the trial we should participate.
Thank you so much. Before we jump into your work at Eureka and what Eureka is doing right now in liver cancer, how does being a parent of children with rare disease influence your daily work at Eureka?
Yeah, that's a very good question. So I've been wearing 2 hats as a professional in the drug industry and also as a parent of kids with rare disease. With my experiences, the first thing I can think of is every day counts. We cannot afford to lose any single day. That's what I told my team. So when we see any roadblocks, when we see some delays, I ask them to really think about the patient and their families and how we can, tackle those challenges and push forward all the activities. So definitely that's, number one. And then now I think the other thing is, I really deeply understand how the study protocol can impact the daily life of the patients and their families. So when Eureka is designing a trial, we want to make sure that we design a trial that is as accommodating as possible so that the patients and their family can still gather enough energy to participate in the trial, but at the same time also design as informative as possible trial to capture enough information for us to bring the treatment across the finish line, and most importantly, to all the patients that can benefit from it.
Wonderful. We're going to bring Dr. O'Neill back, and while we're waiting for her to join, how long have you been with Eureka now, and what is your day-to-day like?
I have been at Eureka for 14 years. In the past 14 years, I have witnessed and actively involved in the cancer drug development, from an idea conception to a real clinical product testing in trials. So it's definitely been a very rewarding journey for me. And I feel very fortunate to actually work in a team full of passionate and dedicated and driven people. My current focus is actually leading the development of Artemis T-cell product for liver cancer indications.
Now we're going to talk a little bit about Eureka, and this is for you, Dr. O'Neill. How did you get involved with Eureka?
It's a great story, actually. I was attending the ASCO meeting, the Society of Clinical Oncology meeting in Chicago 3 years ago. I think we decided. It seems a long time ago now, but the time has gone fast with COVID in the last few years. But I had a poster documenting the role of alpha-fetoprotein, that's that tumor marker you mentioned earlier, and how to link alpha-fetoprotein to prognosis, granted in a tumor other than liver. Dr. Wang was walking by and was struck with the fact that alpha-fetoprotein was something important to her world as well, and the work that Eureka was doing. And so we started talking about alpha-fetoprotein, which in general is a great interest of mine. I think it's a very interesting protein secreted very specifically by these tumors. About 2/3 of childhood HCC secretes AFP. All hepatoblastomas secrete AFP. It's something intrinsic to the disease, and yes, can be secreted in other circumstances and other diseases. When we think about liver tumors, it's so very important in terms of understanding how well our treatment's working. As treatment works, the AFP declines. As a tool for surveillance, when disease comes back, AFP rises. It's a very important tumor marker. And so Dr. Wang and I started talking, and I told her all about my world and my passion for treating pediatric patients with liver tumors and particularly difficult to treat disease. I remember we exchanged business cards, and I emailed her like a week later. I was very much struck by her interest in engaging with the pediatric community. It's very rare for us in pediatric oncology to find an advocate and to find a champion in the world of industry, because we're rare. You know, the diseases we face are rare, but it doesn't make them any easier to treat when we're losing children from these diseases. After having met Dr. Wang, I was like, we have to make this happen. And she was of a similar mindset. And I've been blown away by the availability, the interest, and the compassion and the push with which Dr. Wang and others at Eureka have kind of driven forward with the clinical trial that we worked on together, particularly to offer novel treatment options for patients with relapsed or refractory liver tumors.
And on that note, Dr. Wang, what trials does Eureka have right now in liver cancer?
We currently have 3 ongoing trials. It's called ARIA 1, 2, and 3. With ARIA 1 and ARIA 3 focus on treating adult HCC, and ARIA 2 is actually focusing on treating pediatric liver cancer, including both hepatoblastoma and HCC.
This is for you, Dr. O'Neill, because I always find this fascinating. Pediatric patient sounds very vague. So who qualifies as a pediatric patient?
It's a great question. Anyone from birth to, I say, approximately 18 years of age, because the reality is we often treat children even older than that. You know, children with chronic disease, children we've known for a variety of reasons prior to first, let's say, a diagnosis of cancer. Sometimes we treat within the pediatric realm, even if they are older than 18. But generally speaking, a pediatric patient is defined as 18 years of age or less.
The FDA has a very specific lens as well. What is that?
I'm glad you asked. This is a crusade of every pediatric oncologist out there. The FDA views a child greater than 12 years of age or greater than 40 kilos as an adult. And this is a newer lens through which the FDA has sought to provide options for children before they are definitively adults. And the reason for that is, like I mentioned, the crusade of the providers. There are so many treatment options available to adults that we cannot utilize until they're proven safe in adults. And so we as pediatric oncologists who are consistently treating children with relapse disease or refractory disease are frustrated that we can't access these drugs sooner. And thankfully, the FDA has really changed their viewpoint of what constitutes an adult now. So children, as I mentioned, greater than 12 or greater than 40 kilos are now with more frequency being allowed to enroll in adult trials, being allowed to access medications in a much earlier time frame. Used to be a decade at times, and now we're able to accelerate things much quicker through the pediatric space. Now, what about the children less than 12 years of age or the smaller children? That's another crusade we face, and one that I think the FDA is coming around to in terms of our appeals to start to treat those children earlier with more novel therapeutics.
One more question for you, Dr. Wang. What is T-cell therapy, and how does that even work?
T-cell therapy is one type of immunotherapy. What we do is we actually take out the blood from the patients, and then we extract the T-cells from the blood, and then we engineer the T-cells so that the T-cells can specifically recognize and target and kill the specific cancer type when we infuse those engineered T-cells back to the patients.
And Dr. O'Neill, what are T-cells for those of us who may not know?
T-cells are a very important immune cell. They're a type of, when we categorize what cells circulate in the bloodstream, white blood cells are one of the cell types. Those are the immune cells, and T-cells are a subset of those immune cells that we know are very important in terms of fighting particular viruses, fungal infections, but we also believe are very important in recognizing cancer cells as foreign. But as I mentioned before, they don't always do their job. And so sometimes we have to rely on science to engineer them to do their job better. And I imagine we'll touch on this, but the trial that we worked on together is utilizing some of these engineered T cells to target a portion of that AFP protein that we believe is so important, along with another protein expressed on the cancer cell surface specific to cancers and not to healthy cells in the body, with the hopes of really driving home where those T cells need to go and how they need to fight the tumor.
So we're going to bring Ashley, ladies stand by, Ashley and Presley back to the screen. And while we're waiting for them, we have another poll for you. What would you like more information on regarding Eureka's technology and their clinical trials? Would you like to know how the technology works in solid tumors? How to find out perhaps if your liver cancer is AFP positive or GPC3 positive, and perhaps Dr. O'Neill can elaborate on what that means. The eligibility criteria to participate, which hospitals are participating in Eureka's clinical trials, and what that patient journey might look like. So please let us know. We're going to leave that poll up until almost the end. Actually, while we're waiting, will you briefly explain, Dr. O'Neill, what that one acronym is in the poll there? GPC3 positive mean.
I had just mentioned that the T cells that Eureka are able to engineer target both a portion of that AFP protein and also another protein on the cell surface. That other protein is called GPC3, glypican-3. GPC3 is easier for short. What's so unique about that particular protein, and Dr. Wang, you might want to speak a little bit about this too, is that it is unique to tumor cells. It is not on healthy liver cells, and it's not on other healthy cells. So part of the challenge we face when we tell the immune system to do something and to target something is we want to make sure it's targeting the bad cells, not the good cells.
Right.
You want to make sure that the target is specific to the tumor if at all possible. And GPC3 is a very specific protein that serves that purpose.
So now we have Ashley and Presley joining us. I'm going to take a look at the questions. We're going to start with this very first question. My son has hepatoblastoma, diagnosed at 2 years old. We're now 3 years out of treatment, 9 rounds of chemo with doxorubicin, cisplatin, carboplatin, and resection. My son has high frequency hearing loss, and my question would be, what are the most common long-term side effects of chemo treatment? And besides regular checkups, what can we do to maybe prevent or ease these bad side effects? So Dr. O'Neill or Dr. Wang, whoever would like to take that question.
I'm happy to jump in. I think as is listed in this question, 3 of the most common and probably some of the best drugs that we utilize from a pure chemotherapy perspective are the drugs that were listed in the question. And you're right, cisplatin is the backbone of so much of our therapies. It's a wonderful drug in many ways in terms of fighting the tumors, but it's a difficult drug in many ways because it comes with longer term side effects like those mentioned. So can be very irritating to the kidneys, which traditionally tend to recover over time, thankfully. But it can also affect high frequency hearing. For a very young child who hasn't yet learned to speak, losing the high frequencies matters. They can't hear consonants in a way that we can. They can't drown out background noise in the way we can. And so we know that a lot of these chemotherapeutics, at least for the time being, are here to stay until we can prove that these other therapies do a better job, which I don't doubt over time we will. But because these chemotherapeutics have such a history and because we know that they work for many patients, they are here to stay for some time. And so where our focus has now shifted is where we can decrease the cumulative doses given when possible while maintaining excellent outcomes and survival, or by utilizing other drugs that help mitigate some of those side effects. The perfect example there is that doxorubicin drug listed can affect the heart. We now have a wonderful, it's almost like an antioxidant drug we give with doxorubicin that prevents the heart damage. So we've been studying drugs like that can help mitigate the side effects. And yet we don't have the answer for all. We don't have a paired drug for every chemotherapeutic yet, but it's really our goal to either reduce the total amount delivered or to come up with better paired drugs to protect patients from these side effects, which are undoubtedly real and very important.
That's kind of one of the reasons that we think it's really important to provide this Artemis T-cell therapy to all patient ages, including pediatric patients. And Ali shared with me how limited treatment options these kids have, and also really the lifelong side effects these kids have due to the chemotherapy because of the non-specificity of those drugs. Now we have T-cell therapy, which is a targeted therapy, is supposed to target specifically to the tumor cells, not the normal cells. We're looking at a different kind of drug profile, and hopefully that with that approach, we can actually eventually kind of eliminate those long-term side effects due to the chemotherapy.
All right, this next question is for you, Ashley. Why did the doctor refer Presley to a clinical trial first rather than the standard of care?
I guess at the time I didn't really know, but looking back, she must have spoken, when she went to review the MRI with the radiologist. I'm almost certain that maybe the radiologist had seen HCC before, and because that was the point where she had changed everything. So like I said, looking back now, she probably was certain that it was HCC, which is why she just wanted to get her into a clinical trial.
The next question, again, this is for Dr. O'Neill or Dr. Wang. Should we be concerned much about positive margins?
That's a loaded question. It depends a bit on the type of disease. It depends a bit on the nature of the margin. Just to describe what a margin means, when you go to remove the tumor surgically, you want to take out the entire tumor and leave a healthy rim of normal tissue around it. You don't want to, for instance, leave a rim of tumor behind in the body when you take out the main tumor, because in doing so, you undermine the surgical approach. Really, the surgery is there to cut out everything that chemotherapy couldn't address perfectly. And so if you leave a margin behind, you worry that could whatever was left behind grow back. So I say it matters a little bit because you can imagine a margin could be very big or it could be microscopic. And we know in hepatoblastoma, we know that sometimes a microscopic margin is okay. And I say that because recall, hepatoblastomas respond so well to chemotherapy that often you can kill those microscopic cells left behind with the rest of your chemotherapy. I personally think HCC is completely different. Our therapies are not yet good enough. That's why we're stuck with so many patients that either present with an advanced stage of disease or come back with disease having returned, because what we can offer to give, if we can't resect the tumor completely, if we can resect the tumor completely, I think, Presley, you're the perfect example. It's definitely a different scenario altogether, but it's so very important to take everything and leave nothing behind. So I think positive margins in HCC are problematic. And I just want to say, Presley, you're so brave. I love that you came on today to share your story. And I never fail to appreciate hearing from people your age, because we don't always know what you understand and how you reflect on everything you've been through. And I think it's really important. I mean, I see thousands of children, and I always hear a different perspective when we ask you. And so I think that's so invaluable. And Ashley, I just want to say that you've been an incredible advocate for your daughter. I mean, you knew to advocate because you came from a medical place, and you just knew, you had your intuition, and not every family necessarily even has the knowledge to advocate in the way you were able to. So I think that's so very important. So I just wanted to thank you both for sharing your story.
Thank you.
And I will add to what Dr. O'Neill said, Sushma from India, and that's what she was asking about, the positive margins. Her son was diagnosed with hepatoblastoma. He's had a resection in the right lobe, and he's been in remission since the last 6 months, AFP in the normal range. Rightfully, this person's very concerned about the positive margin, even though it's less than 1, I believe that's millimeter. All right, so here we have another question. My son's 10 years old, was diagnosed last year with stage 4 HCC. I'm so sorry, that was exactly my sister's diagnosis. He had a liver resection in April, scans in June showed a relapse. We don't know what's going to happen because his oncologist said he has tried the best treatment already. So I'm not clear what the question is, but I'm going to go ahead and just take that information and ask it. How common is it for HCC to return, to relapse? And what would be not your medical advice, but your suggestions for this parent moving forward?
Unfortunately, it is common when a patient presents with stage 4 or disease that has already spread. It's common not only to have difficulty in ridding the body of all sites of disease, but it's also common for disease to come back. So I'm so sorry that this is the circumstance you're in. But I also think that this is the circumstance in which clinical trials are so very important. The term clinical trial can sound scary because it can sound like a big experiment. I think the thing to impress on everyone is that thankfully we're not allowed to experiment without very consistent and convincing science that leads us to believe the treatment can work. Are we right about that every time? No. Sometimes the treatment works beautifully in the laboratory and not as beautifully in the patient. The steps we have to go through to convince not only ourselves, but the Food and Drug Administration, all the ethical boards, and to really believe in the science that shows that this has a real shot. There's so much that leads up to that before a clinical trial is even launched or allowed to launch, that we as physicians follow something we call equipoise. And what that means is really do no harm. Mm-hmm. So we would never offer something unless we felt it A, had the prospect of benefiting the patient, and B, we don't feel like it will cause undue harm. And that's the principle with which we have to practice. And so clinical trials that exist, if they are available for difficult circumstances like this, are very important to consider. And as a parent, looking into what trials are available, where they're available, I can speak for myself in the rare cancer field. We're always happy to talk to patients and families and to understand more about what your child is going through and whether there are opportunities available for promising clinical trials, because these are the circumstances we know are difficult and the ones that we're eager to help with.
If Anel is interested in learning more about the clinical trial, is it possible that her son would be eligible, just knowing what little we know right now?
Right now, the ARIA-2 trial that is focusing on pediatric liver cancer, we need these patients to be A2 positive and AF positive. So those are kind of two big screening criteria we need to hit before we can consider further testings for the patients. If you're interested in learning more about the trial, contact us, and I'm sure Dr. O'Neill will be very happy to talk with you offline regarding your own case. Yes, we did tremendous work scientifically to demonstrate the safety and efficacy, of course, in the in vitro settings and in the animal models before we can bring this treatment option to the clinical trial in human. And on top of it, as I just mentioned, we have 3 ongoing trials and specific T-cell product that we offered to the pediatric liver cancer patient. We also are testing out in the adult HCC setting. And there we have already enrolled a couple of patients. We are very pleased to see that the safety profile is as we expected. And we're just looking forward to see more kind of signals, positive signals, once we escalate to the therapeutic dose level.
We have another question here from Anne. Our son was diagnosed with hepatoblastoma 3 years ago at the age of 6.5. He had multiple relapses, resections, and finally a liver transplant in October of 2021. In January of 2022, his AFP started rising again, and we had to analyze the initial biopsy, and it came back HCC. Anne's question here is they keep trying different medicines, but now he has several tumors in his new liver and one just outside the liver. They are from Israel, and they've had all the resections and transplants in Chicago and would like to know more about treatments for their son as they're trying to keep him alive and hopefully healthy. Either one of you, Dr. O'Neill or Dr. Wang, could you comment on, first of all, I'm so sorry, Anne, but wow, going from hepatoblastoma, going through all those treatments, resections, and then getting a new liver and then having it come back as HCC. How common is that, and what can this family do?
I'm so sorry to hear about what you're going through as well, but I'm happy you're here. And I think the question you pose, Andrea, is a good one. How often does that happen? Disease doesn't usually change. You don't usually start as hepatoblastoma and transition to HCC. The realities are it was likely always HCC, or on occasion, when hepatoblastoma recurs more than once and is exposed to a lot of drugs, it starts to look different under the microscope. And so that's when we sometimes question whether it is HCC. But the realities are, I think it's one of those two circumstances, but a really hard one to be in. I think the challenge too we face is that when patients, and I'm sure this is something you're aware of, when patients have a liver transplant, what we do is we immunosuppress that patient because we want to keep the liver healthy and happy. And not perceived as a foreign organ in the patient's body. We give medications that dampen the immune system a bit so that the body doesn't view that transplanted liver as a foreign organ, but rather maybe something new, but something they're willing to live with. And that's what's so incredible about transplanted organs is that we found a way for patients to live decades upon decades of health with a new organ. The challenge there is that when you dampen the immune system, you then can't rely upon it with immunotherapeutic drugs as well, because you're purposefully calming those cells down when in reality, immunotherapy is calling on them to rev up. So we have to think more creatively sometimes about therapies in that context. You're more than welcome to reach out to our liver center such that we can collect more information about your child, understand what your child's received thus far and what we can perceive to be additional treatment options. And I'm happy to speak with your physicians, be it in Israel or Chicago, to see how we can help further.
This question is for Presley. Do you have to take medication every day?
Yes, I do take medicine every day. I am currently in transition from tacrolimus, trying to get off of tacrolimus onto sirolimus. So I do take 4 milligrams of sirolimus and then 1.5 of tacrolimus every day to make sure that I have a suppressed immune system to prevent any rejection.
Ashley, what is the difference in those two medications?
They're both the immunosuppressants, and tacrolimus, I believe, is probably the most common. But Presley's situation is just a little bit different. She's having a little bit of bone marrow issues, so they're attributing it to the tacrolimus. So we're kind of trying to wean her off of that and get her bone marrow back up.
And Dr. O'Neill, I want to ask, so once someone has a transplant, let's focus specifically on liver transplants, how long does someone have to keep their immune system suppressed? How long do they have to take medication?
It's lifelong immunosuppression, but the benefit we have is that you can lower the amount of suppression over time. The body does accommodate to this organ. When it first receives an organ, it's taken aback, but then it settles in, and it becomes a relationship with the body. And so you're able to slowly pull back on the amount of immunosuppression required to maintain that nice balance in the body. So while it is lifelong, thankfully you have the opportunity to kind of pull back on that treatment over time.
Thank you. That's so helpful. I have closed the poll. I just want to talk about it a little bit. So we do have people who want to find out if their liver cancer is AFP or GPC3 positive. We do have people who want to know about the eligibility criteria. But here's a question I think we can answer right now. So what hospitals are participating in Eureka's clinical trials?
Specifically for ARIA-2, currently we're actually collaborating with Dana-Farber Cancer Institute, of course, Boston Children's Hospital. While we learn more about this product, we will definitely open more trials across US first, and later on maybe we'll consider open sites outside of US.
I just want to thank our panel. I want to thank Dr. Allison O'Neill, Dr. Pei Wang. I want to thank Ashley and Presley for bringing that personal perspective. I really appreciate your time today. Thank you so much to everyone from Germany and India and New York. If you have any more questions about Eureka Clinical Trials, first look for that email that you're going to receive with the replay. You can respond to that. And also click that button at the bottom that says learn more about Eureka Clinical Trials. That goes to their patient-facing website. It's very easy to use, so I highly recommend you go there. I want to thank you so much for your time today. We appreciate you so much. And if you are watching the replay right now, what's great about the questions is that you can jump immediately to each person's answer. So when you see these questions in the question area, you can jump to each person's answer. Everyone, thank you so much for your time. We're going to let these ladies have a little bit of their time back today. So I want to say thank you again so much to Dr. O'Neill, Dr. Wang, and Ashley and Presley. Please subscribe to Blue Fairy's channel here on Crowdcast for more workshops like this one today.